Hello, everybody. I'm Linda Geng. I'm one of the co-directors, along with Dr. Hector Bonilla of our Stanford Long COVID Collaborative. It's been really amazing to listen to all these great talks, and hopefully we'll also hear the end of Dr. Martin's. But in the meantime, we do have a lot of great questions for some of our other speakers, and some of them have, as I mentioned, been answered as well live. And I'll try to summarize a few of them as well. Let's start back with the ENT questions. And Dr. Patel, you have several, and maybe some of them you can also, link to. You mentioned the initiative that you all started in the website, so people can look at those resources. But there were some technical questions about the therapy management strategies, like how do you rotate? Do you rotate scents in terms of the smell rehabilitation? Do you bring on new scents? How do you exactly handle the scent sequence?
Yeah, so thank you, Linda, for pointing out that all of the studies that I just talked about are linked to on that website. So if you go to the treatment options tab of that Stanford Initiative to Cure Smell and Taste Loss website, then all of this is linked and you can actually click and read the whole abstract. And if you have access, go to the actual paper. But let me try to address as many of the questions as I can now. So when you do olfactory training, we start with those four that I mentioned, and you just rotate through those four. But you do want to add eventually more smells because the more variety of odors that you train with, the more effective the training will be. So I have actually, this is also linked on the website. I've done a whole patient education write-up for JAMA about olfactory training. And if you read through it all, you'll get all the information. But I've written in there at 1 to 3 months the odors can be changed. And I've given some examples of different odors, but really the exact type of odor does not matter as long as there is a good variety. You don't want to be training only with floral or only with all fruity scents because you won't actually activate all the different types of olfactory receptor neurons that you have at the top of the nose. So as long as there's a good variety and as long as the patient has a memory of what that smell is supposed to smell like, that's kind of the key component that they focus on. Those are the important things.
Great, thank you. And then there were some other questions as well about budesonide in terms of optimal position and omega-3s in terms of dose and whether you would use combinations such as fish oil.
Yeah, so the head position for rinsing to actually reach the olfactory cleft is kind of like an all the way upside down head position. So I actually, demonstrate this for my patients in clinic. I'm gonna maybe try to make a video to also put on that website. But right now, just my regular sinus rinsing video is posted there. And just for to get the sinuses, you get your head a little to the side, a little head hanging forward, and you have the flow going through the sinuses from one side to the other. But in order to really reach highest, deepest part of the nose, the olfactory cleft, I really say, easiest to do in the shower, standing up, so that you can really get yourself all the way upside down. And then as you feel the flow go through your nose, point the top of your head to the floor. So really all the way upside down. That is really what will deliver it best. Now, of course, there are some elderly patients or patients with spine issues, people who can't actually do that. And so really probably any amount of rinsing might get a little bit in and out of that cleft, but getting all the way down is the best option. And I'm sorry, Linda, you were asking something else. I can't remember.
Oh, it was about omega-3s and the dosing. But maybe if you could type in the website again for folks in the chat,
Yes,
for the audience, that would be great, or in the Q&A. And
I
then
will.
thank you. Thank you so much.
Yeah,
And actually, Dr. Martin's back, so maybe we can finish up that and then we'll go back to the Q&A as well.
sure.
Thank you so much. Dr. Martin, please feel free.
All right, sorry about that. Multiple things.
Okay, great. If everyone on the panel could turn on their cameras and then we'll get to the questions. And there are certainly some as well for Dr. Martin. You can continue some of those topics as well. And then in terms of, so we have still several of the ENT questions, but I think we found the website to be able to post on the Q&A. So for those who are interested in the protocols, please do look at the wonderful website and resource that Dr. Patel and team have created. And then we'll also loop back. But in terms of headache as well, there was a question about any information, Dr. Muscatel, about vestibular migraines after COVID or vestibular symptoms in general post-COVID.
Yeah, absolutely. So we have certainly seen patients who have had new or worsening vestibular symptoms, either on their own or associated with migraine. And, with vestibular migraine phenotype, we are specifically looking that those vertigo symptoms are happening in association with the headache itself. And when we approach treating vestibular migraine, there are some of those preventative therapies that we try to drift to when possible. So venlafaxine, for example, the SNRI, has some trials to suggest that it can be effective for vestibular migraine. Similarly, the injectable CGRP monoclonal antibody galcanezumab also had a recent clinical trial that came out that showed that it had efficacy for specifically vestibular migraine. And so those two can be great options for your patients who have post-COVID vestibular migraine. And additionally, beyond pharmacotherapy, vestibular physical therapy is another critical tool that we use. So it's very rare that we just use a medication to treat a patient with post-COVID vestibular migraine, and we'll use that combination of both medication as well as vestibular physical therapy, and if needed, a referral to our dizziness clinic as well.
Great, thank you so much. Really comprehensive care, multimodal. That's really fantastic to learn that. And then going to GI as well. Thank you so much, Dr. Gubatan, for answering some of these. So I encourage the audience to look at those questions that have been answered. But you did mention also, there was a question about bloating, and you had mentioned evaluating for SIBO. And that was actually a question that came up as well, is what is the role of evaluating for SIBO? And do you often see SIBO in long COVID? And then also, there was some discussions about SIBO and brain fog. Is there a relationship there? There's a lot of brain fog in long COVID. So can you, have you treated SIBO and seen improvement in brain fog? Because there's a lot of questions related to SIBO. If you could just comment about that. Thanks.
Yeah, these are all excellent questions. And part of our workup for any functional GI disorder, breath testing for SIBO is part of our standard testing. So anyone with any bloating, I send for a glucose breath test. And it's pretty easy to use. You can come to our lab, or we can mail the kit, and we get results pretty quickly. And so I have seen several post-COVID SIBO alone. And so we just treat them, test and treat. And then the brain fog is actually something I do see actually a lot with SIBO. We don't know how it works, but somehow maybe some of the bacterial metabolites cause some alterations in brain function. We don't really know, but I have seen patients who improve just treating with rifaximin, treating SIBO with rifaximin, and it clears their brain fog. So I think it's something that we don't have much data. As you can see with the literature presented, there's SIBO wasn't even included. So that's like a ground for more research. But I do think there is some anecdotal small cases of a relationship with COVID that needs further research.
Thank you so much. And then Dr. Martin, for hematology, there's a question about, could microvascular thrombosis be pivotal yet under-recognized consequence of COVID? I think you alluded to and talked about this a little bit, but maybe you can dive a little bit more. This person had asked that autopsy studies had consistently revealed widespread microthrombi across multiple organs, even in patients receiving anticoagulation therapy. And perhaps then you can also speak about, the literature and sort of the hypothesis about microclots and what would be the role of anticoagulation and the risks. This is a question that often comes up with patients reading things online and then asking, should I be on triple, anticoagulation therapy? What is the thinking about thrombosis or microthrombi, microclots, and anticoagulation? Thank you.
Sure. So at least in the literature that I read, and we have presentations every year at the International Society of Hemostasis Thrombosis. Unfortunately, it's timed this year next month, so I didn't have advantage of new information. But just as in sickle cell disease, so it's a very similar process, anticoagulation doesn't seem to change outcome with time. Now, the problem with autopsy studies in looking at thrombosis is as clots rapidly happen immediately at the time of death. And they actually rapidly happen in about the 6 hours preceding death if someone has been actively dying. So that's why you'll see that over 48% of patients, I want to say it's 80% of patients by autopsy have DVT and PE, or at least DVT, whereas you're running around 4 to 14% if you look at live people. So you have to be very careful with that. But we can still learn a lot, especially if they are looking for nets in this. So I'm not trying to oversimplify it, but but the consensus from the literature, and again, based on sickle cell and some other models that are very similar, is that probably neutrophils and platelets with macrophage activation are behind the microthrombi. And so that's why simple anticoagulation, and at this point, using antiplatelet therapy, because these are usually not propagating rapidly, it's what's residual on the surface. And so we run into the problem if these are antiphospholipid antibodies, we don't have great therapy for it. Rituxan doesn't help. We try it, plasma exchange. So I think that if we see breakthroughs in either treating that histone DNA and cleaning that off, because apparently our body does not have a system for clearing that out like it does fibrin. But I do think that in one of my slides, we have to look really carefully at the patient's cardiovascular risks overall. And I know that doesn't answer the brain fog question, but these patients are at exceptionally high risk for stroke, other cardiovascular complications, early death from disease. And we think that this is actually underpinning in cancer patients as well. Why early death is often due to cardiovascular and not their cancer. It's probably the net process that propagated this, and then the autoantibodies. And so we should look very carefully. And I think in the chat, there was a question about whether to stop Plavix. As you can tell, I'm a big believer if someone has normal renal function of testing lipoprotein A. If it's above 100, it really should be referred to a cardiologist for consideration of reduction of that, because your standard statins won't. But all cardiovascular risk factors should really, really be tightened up in these patients. If they have other risks for having a venous thromboembolism, then you would use all of your other guidelines for that, the CHEST guidelines, because it's interesting, as it turns out, once people recover from a thrombotic event, a venous thrombotic event with COVID, acute COVID, they actually don't have a higher risk than an average patient without COVID going forward. There's always a risk. It's 2 to 4% per year. So there are patients you might continue chronic anticoagulation based on that, but you can follow the usual guidelines in these patients. And there's no evidence right now that says, unless somebody truly has antiphospholipid antibody syndrome with long COVID, that they would need to be chronically anticoagulated. But right now, there's no data that I found, and someone can correct me if I'm wrong, that these combinations of therapies are helping what are measured outcomes in the patients. So it's truly case by case. To save them from death from something else, I don't think it's likely going to improve their current symptoms.
Thank you so much. Thank you so much. Yeah, this has been a really kind of active area of research and discussion in the field. So thank you. And looping back to Dr. Patel for ENT, could you speak to a little bit about the distinguishing? There's a question about hyperosmia, for example, hypersensitivity to certain food, odors. And then there was also a question about aparosmia. And so what's the difference, anosmia, parosmia, hyperosmia, and why would people get these different manifestations? Thanks.
Yeah, so anosmia is total loss of smell. Hyposmia is a decrease in smell. Parosmia is a distortion of smell, unfortunately, most of the time bad. And then there's phantosmia, where people smell things that aren't there. And then hyperosmia is actually a little bit of a misnomer. Hyperosmia, we would mean to indicate that someone has a hyperacute sense of smell. But what really people are talking about when they use hyperosmia often is a hypersensitivity in the nose, an irritation type of phenomenon. And that is not mediated by the olfactory nerve. It is mediated by the trigeminal nerve. The trigeminal nerve is a different nerve that has nerve endings throughout the entire sinus and nasal cavity, all throughout the face and skeleton, all this area. And different than a trigeminal neuralgia, trigeminal hypersensitivity can occur from any irritation or inflammatory event. So certainly COVID-19 could precipitate something like hyperosmia, or what I like to say, just trigeminal hypersensitivity. And so treatment of the smell system is not going to be the answer for that. There are things like lidocaine sprays, decreasing inflammation with high volume steroid irrigation. Sometimes that helps people. If that's not enough, there's a facial pain clinic actually that does blocks and things like that can help some people with that. The other part of your question about parosmia and the difference, specifically in COVID-19, we see people developing both, and the underlying mechanism is just different parts of the same dysfunctionality of the system. the theories behind why people develop this distortion of smell range from just a lack of neurons. So most odors are quite complex. So coffee is a very common example that people have parosmia with. Coffee is a very complex odor. There's many, many different molecules that are entering the nose and attaching to different types of olfactory receptor cells. If you are missing some of those olfactory receptor cells, you're just getting the signal from the ones that were activated, missing the others, and then that doesn't, send the right signal to the brain. The other idea is that there's a miswiring. So when nerves are activated in the nose, they're not connecting to the right place in the olfactory bulb and brain. I suspect it's more the first versus the latter, but we don't really have a good understanding of that yet. But they really are both possible and part and parcel of the same phenomenon of dysfunction of the system.
Thank you so much. Great. We're getting a lot of inflow of questions, so hopefully we can get to them. But if not, if the specialist, if you could type any, that would be great as well. Dr. Muscatel, regarding, let's see, yeah, it says pathophysiological basis. Why would COVID increase both migraine and tension headaches since they have different etiologies? And I think somebody else also had what would be the cause of why COVID is triggering or worsening some of these headaches?
And that's a really great question. So overall, this all has to come down to how an acute infection activates the full inflammatory cascade. So in patients with migraine, what we know is that they have higher circulating levels of IL-6, TNF-alpha, and IL-8. We know that IL-6 and TNF-alpha could be associated with fever and be activated by the initial inflammatory cascade that can kind of kick off as associated with COVID. And that inflammatory cascade not only has those cytokines that get activated, but there's also a specific nod-like receptor protein 3 inflammasome that will then activate, IL-6, and that can in turn cause the activation and sensitization of mucosal and meningeal trigeminal nociceptors, and then that will trigger the headache. And so that's kind of our understanding of the acute phase. And then those specific reasons for why patients have these persistent headaches afterwards is still kind of ongoing, and we don't have a great understanding for that. However, we do have a fair amount of precedent in that prior to COVID, for example, many patients have presented with other types of either viral respiratory infections or GI infections or other types of infections and have significantly more headache frequency afterwards. Now, given that migraine and tension type headache do have significantly different pathophysiological underpinnings, we think that with tension type headache, a lot of that is with that initial inflammatory cascade kind of activating additional kind of myofascial pain receptors that kind of lingers afterwards. Again, headache research is underfunded to begin with, and we haven't been able to fully address this question.
Thank you so much. And for GI, Dr. Gubatan, you may be answering this already, but there was discussions or questions about probiotics and sort of the microbiome. And I've seen this as well. There was even a trial, I think, out of Hong Kong where they tested some kind of prebiotic and probiotic mixture to try to help with symptoms. What are your thoughts about that?
Yeah, in general, probiotics are good for general GI health, and currently we don't have robust guidelines for the type and frequency of probiotics, but we're actually referring to the same study published in the Lancet Infectious Disease. There's some data that suggests that bifidobacterium-based probiotics can be helpful in long COVID. So I think, in the absence of guidelines, any probiotic that has bifido could be potentially helpful as a starting point.
Great, thank you so much. And Dr. Martin, there's a question for patients with a known clotting disorder, such as protein C deficiency. Would it be beneficial to start short-term coagulation when diagnosed with COVID?
Yes. So anyone with known clots, known high risk, just follow your usual guidelines. Again, it's just unfortunately, I don't think it's going to help their other COVID symptoms. And I think that also, patients need to be educated if they're in situations where they would be at risk for provoked DVT-PE, that they need to alert you so that they can get appropriate anticoagulation. Oftentimes, say after abdominal surgery of any type, they should have anticoagulation prophylactically for 6 weeks after that, 6 weeks after pregnancy, so that very long plane flights, those 12 and 15-hour plane flights, they should be anticoagulated around the time of flying, and wear good compression garments. So to follow those usual guidelines, to treat them as real, and that they will only worsen as they age, and probably only worsen because they have the inflammatory disease of long COVID.
Thank you. And for Dr. Musk, going back to just thinking about thrombosis risk, potentially increased in individuals after COVID, have you seen, which is otherwise a rare phenomenon, central venous thrombosis being increased after COVID in headache population?
Not particularly. We have not seen that as a complication that has been one of the main phenotypes that we've seen. I think I have seen one case at some point, but overwhelmingly they're the kind of patterns that we discussed.
Great. Thank you so much. And I will say there are a few questions that actually I think our afternoon session, which feature our excellent guest speakers from physical therapy and other disciplines as well, that could address. And just thinking about exercise or manual therapies and physical therapy for other management strategies. And then there was a question also about visual acuity. This one, there is some literature about potential visual changes after COVID as well. Not a really well-studied area. I'm not an ophthalmologist. We don't have one on our panel today, but I will mention that there is some reported literature about that as well. And there was discussion also about a question about Paxlovid. And I think Dr. Patel, you had mentioned, potentially preventing long-term loss of smell. And then can it help prevent other long COVID symptoms? And there have been large EHR studies to suggest that there's some preventive effects. But Dr. Patel, I don't know if you wanted to add anything else to that.
I think you're probably the best person to talk about whether or not it helps other symptoms. I think probably some of our viewers know that you have headed up, a really big study looking to see if there is any benefit for many other of our COVID symptoms that long COVID patients suffer from. And, just to keep in mind that my study was, not a prospective study. It takes a lot of time and money and effort to run a prospective study and really separate patients out, randomize them, things like that. And there's so many different things that we want to test for. So smell was not one of those that we could test for in that prospective study. So mine was a retrospective study looking backwards, and that did seem to separate out. Now, keep in mind that in a retrospective study, there are so many confounding factors that we don't have the ability to control for. And, it would be great to be able to run a prospective study and confirm that type of finding. For me, smell and taste is so important to my quality of life that would prompt me to to use it if I ever got COVID again, just because I think it could potentially help me. But I think to each his own as far as how far you want to take that recommendation.
Yeah, and it does seem like there's a distinguishing in terms of prevention of long COVID symptoms, so taking it during the acute period versus our trial, which is testing people who've had 17 months or longer of symptoms and already have long COVID and trying to treat it then. So far, the literature hasn't borne out for that, but there are other trials ongoing right now testing longer durations in different populations. So it's TBD, but yeah, for prevention, it does seem like EHR and some of the retrospective studies suggest preventive capabilities. And I think we are at time, but there's such an amazing, robust discussion and lots of questions. So thank you all so much to our expert panelists. Learned a lot today, and we have another session coming up. We have a break right now and really looking forward to it. And thank you all to the audience as well for asking these great stimulating questions. So really appreciate it and grateful. There's lots to learn and progress on this field. Thank you all.